because they were focusing on treatment. But if you downstage a disease, you will spend less. But I don't think that concept is still there. Maybe because in the US, they have gone past that stage. They have got a hold of treatment and protocols and things like that. India is still struggling with that. So maybe that's the reason I wasn't able to convince the director to include prevention. But I think that's a great thing to do, education, prevention, talking to the patients when they come about how they get passed on for breast cancer, for instance, for the family. They don't know. The doctor has no time to talk to them to see that the others in the family are even checked. So that's my passion now, to do any kind of prevention. And Arogya, when I met Sashi, and very recently, and when I saw what they were doing, the education, and piggyback on that, the health education, I thought that was a brilliant idea. So I think if we can do more on that, that would be great. But I don't want to take any more time, but I have the distinct pleasure of introducing our next speaker, Dr. Thakur Patel, retired Captain, Medical Corps, United States Navy. So he currently serves as the Adjunct Associate Professor of Medicine at the Uniformed Services of the Health Sciences in Bethesda, Maryland. Following his training in nephrology and internal medicine in 1979, Dr. Patel joined the United States Navy, where he served for 23 years. And he has a lot of experience in different assignments, which I'm not going to detail, but he is board certified in both medicine and nephrology, and is a master of the American College of Physicians. After retiring from the Navy in 1998, he joined the Department of Veterans Affairs in Washington, D.C. as the program director, renal diseases, diabetes, and oncology, the three big diseases. Throughout his career, Dr. Patel received numerous military and civilian awards and has several articles to his credit. He retired in 2007 and is now actively working in the public health area and is a Red Cross volunteer as a nephrologist at Walter Reed National Medical Center. And Dr. Patel's current passion, however, is to improve healthcare in the villages of India. And we've just heard what we can learn from others in Iran and see healthcare. Now let's look at what Dr. Patel has to share with us and the Sevak project. I'm not going to say any more, but invite Dr. Patel to come and tell us more about his dream.
Thank you very much, Shashiji and Krishnaji. Thank you for inviting me to this session. And Sevak project, next. This is when I retired from the Navy in 1998, I was at the American College of Physicians and the president of API, American Association of Physicians, invited me to be chairman of Public Health Committee of API. And my question to the president was, what do you want me to do? Do whatever you want to do. So I said, all right. And then the president moved on. And the next one was an orthopedic surgeon. And I said, you know, we should study the Indian Americans in this country. I said, I've never seen so many ignorant doctors as the Indian doctors in this country. And he says, why are you saying that? I said, I'll ask you only one simple question. What is the prevalence of diabetes in our own community in this country? He says, it's very high. So I said, now imagine what you just told me. We are all scientists, we should be data driven. What is the number? And he says, well, it's high. So what do you want to do? I said, first we must study our own community. And with Dr. Mishra, Dr. Padmini Balagopal, we did this national study in 1,000 Indian Americans in Houston. This is not very common knowledge. It's published, but not very common knowledge. But it's 1,000 Indian Americans. It's a random study and first of its kind in Indian Americans. We did the study in Houston, Washington, D.C., Edison, New Jersey, Boston, Phoenix, and San Diego. And if you look at the first, I'm going to go briefly on this one. Look at this prevalence of diabetes, 17.4%, and pre-diabetes 32%. This is in United States. If you look at urban India, we partnered with All India Institute of Medical Sciences. And they studied a middle class community, which was the railway colony in New Delhi. And the prevalence there was 14% roughly. Pre-diabetes 23. In rural India, we studied 6 villages in Tamil Nadu. And the prevalence was 8.4%. And pre-diabetes was 12%. Now, with this information, and Dr. Padmini Balagopal was doing the study in India. She was running around between Delhi and Chennai. And we did a village in Gujarat also, because I wanted to see if I can stimulate research in my own medical school, which is in Baroda. And we did a village 40 kilometers. In India, 40 kilometers is like 400 miles in this country. It's just fascinating. And I think it's similar in Iran also. So anyway, we did this study in this village, and she called me one day. She said, I have 300 people with high blood pressure. What do you want to do in this village? And I said, I haven't got the vaguest idea. And I think you mentioned about it, that once you do data, what do you do next? I mean, once you have a data and you know that this community is sick, it's a moral obligation to do something about it. And I had no clue what to do. But after about 2 months, I realized that in the Navy, I was the director of a program called Independent Duty Corpsmen. So we do have CHWs in this country, in the United States government, called the military, we call them docs in the Navy. They're trained for a year. And then we put them on these cruisers and destroyers. And they are the independent providers of healthcare on these ships. Mind you, these are healthy people. But if you look at their capabilities, huge. I mean, taking from trauma to preventive care, everything. Including checking the engine, humidity, environment, water, sanitation, all that comes in the realm of this IDC. So I said, why don't I just take this model, shorten it to what I need for the villages? And that's what we did. And we selected 26 villages. At that time, there were 26 districts in Gujarat. And we also asked, we took 1 village per district of Gujarat, so for a total of 26. The reason for taking 1 village per district is to get rid of disparity. Between districts, there is huge disparity in income. Next. This is a map of Gujarat. So, by the way, just as a side note, I was not born in India. I have very little to do with India. The only thing I did in India was study in boarding school and then went to medical school and came straight to US. But I have a passion for India. I love India, I mean. And that's the reason to go back and do something. So with that 300 people with high blood pressure, we decided to do something. So Sevaks live in their villages and do screening for diabetes and hypertension. Because we found hypertension, everybody knows that if it's uncontrolled, people do die and have complications. And diabetes, same issue. But in these villages, there is no screening. Nobody does screening for blood pressure or diabetes. Next. Now this I put up to show you a lot of pictures. This is interesting. For example, we have patients with diabetes in villages who are on insulin. There is also type 1 diabetics who are on insulin. But they do not have glucometers, they do not have a refrigeration also. So this was my attempt to stimulate the engineers that you must do research based on the village needs, not on what you think would sell in the western part. A lot of the engineers, IITs in India do research, but it's for the western journals. And simple thing like this, these are earthen pots, but if you put charcoal, salt and water in this area and put your insulin vial in the center, you can lower the temperature at least by 20 degrees from the surrounding. So I said, why don't you validate this? This is another, next one is, this is a chula. Everybody knows chula, right? So in a lot of these huts, now mind you, most of India lives in huts, no matter who says what. And in huts, they burn wood. There is no ventilation to the outside for this. So you have children growing in the same environment. The father is probably smoking bidi, adding to this smoke. Next. So this is an efficient chula. See this one, you burn the wood here. You can keep the water or food warm here. There's a connection between these two. And when the smoke goes out, you can add water to this. There's a tap here. So you have three things going on simultaneously. Next. We taught the sevaks how to build these chulas. Not that anybody has built so far. I keep asking, has anybody ever built one? Actually in a village, they haven't done it. It's one of those growing pains that you have. We started the Sevak project in 2010. Next. Now this is the anemia chart. That's why I was asking, how do you measure hemoglobin levels? This is an anemia chart, which is fascinating. You have the pictures of tongue. It's not very nice, but it goes from very pale to pink, and it gives you levels of different hemoglobins. Next. This is a Sevak in Kutch. He is going on one of his visits. Next. This is another Sevak collecting data. Next. This is a Sevak who has a group session about lifestyle modification, diet, and all that. Next. Now this one is a village in Sonal Nagar, Kutch. This is, I call it like world's end almost. About 20 kilometers away, you have that water, and across the border is Pakistan. So that's how far Kutch is. This lady is 35, was 35 then, with insulin-dependent diabetic. She had several episodes of hypoglycemia. And I told this Sevak that she should look after this girl and check her blood pressure. She has two children. One has CPs, cerebral palsy. Her husband has a tea shop on the main road. So poverty is very much alive in India. Next. She died, by the way, year before last. This is another Sevak checking blood sugar. Next. This is also Sevak checking blood sugar. Next. This is the Sevak who is only 10th grade. Now she is also an Asha worker. Asha workers in Gujarat are assigned villages. They go and treat for fever, malaria, diarrhea, aches and pains. So they have 10 different pharmaceutical agents in their little bag, and they can treat this. This is another Sevak in Surendranagar and Patan district. Do it. He is the son of a priest. All of the Sevaks have to live in the village in which they work. Next. Another Sevak checking blood pressure. Now, this one, he's a policeman in his regular life. All the Sevaks are part-time, they're not full-time. He's a policeman during his regular work, and he does this on weekends, early mornings. Next. This girl, what has happened in the Sevak project is, a lot of the Sevaks would identify special cases. This is one of those. She has scoliosis and kyphosis, and I had him take her to Ahmedabad to see if any orthopedic surgeon could operate on her and help her. She was bedridden. Next. What we did is, since there was no physical therapist to go there, I had that Sevak go to a physical therapist, learn the exercises, and train her on them. This is one of the hospital beds which we got made in Baroda with this superstructure to help her lift herself out of the bed and actually walk around. This is a walker. So we took all this from Baroda to her house, which is basically a hut also. Next. Now she's able to stand and actually try to walk, which is a huge progress because this is only 3 months since we gave this bed to her. Next. Now the data on the Sevak project is we have about 30,000 today, And male and female, same. Next. We collected data on everything. Since we are collecting data, we said, let's do everything in the village and at least get an idea on what we are dealing with. 28% of the villagers have no formal education, 31% only elementary. Some high school, 13.6%, 4.3%, some college or technical. Look at all this. These are so low numbers. So, you know, if you want to implement anything, this is what you're dealing with, which is very tough. And since the theme of this is education and health, this is where our focus is. Next. Even if you look at the income level, there are only 2.2% of the villagers who are employed for wages. Sorry about this. Only 2.2% are employed, 34% are self-employed, and out of work, 2.4%. But this homemaker, in the villages, homemakers also work in the farms. So they have double duty. Then students are only 3.5%, retired and unable to work. Next. Tobacco use, 13% in this one, smoking 8.3%. Somehow, I find it low, but that's the number we found. Next. Look at the toilet, 45.5% have toilets. That's another thing that we emphasize in the Sevak project, that you must educate them on the need for toilet. And 54% had no toilets actually, sorry. And the source of water, these are the various sources of water. So it's really a mixed bag. But most of the villages have village tanks, 65%. Next. This is the form of fuel. Now, 25% still burn wood. But most of them have stoves and a combination of stoves. Next. Chronic diseases, we have 3.4% with diabetes. Now these are really rural villages where they actually work in the farm, most of them. If you took another village that has a mixed population of haves and have-nots, the prevalence is about 8 to 10%. But in these villages it was 3.4%. But 2.3% did not know that they have diabetes. Next. In hypertension, 6.5% had hypertension. And diastolic was about 2.1%. So between the two, it's about 8% with hypertension. Next. Now, we also have a project in Guyana. Next. This project is similar to the Gujarat model. The reason I got involved in this is because of Dr. Jinda, who is a transplant surgeon, and he says, why don't you do something in Guyana? And Mr. George Subraj is a philanthropist from Queens, New York. He's a Guyanese and he likes to give back to his country. He himself doesn't own even a house in Guyana, but he comes on every trip. And Swami Aksharanand is the one who runs the Saraswati Vidyaniketan. Next. We took 6 sevaks from the school. And there is a critical need for sevaks in this country because they don't have public health hospitals. If they have, most of them are run by Cubans. And somehow, there is a huge language barrier. And 51% of the population is 3rd, 4th generation Indians. 48% are African descent. Next. And Mr. Subraj sponsored this whole project. He pays for the sevaks. By the way, we pay about 2,500 rupees to the sevak in India per month. And in Guyana, about $50. Next. This is a school. Next. These are the sevaks with it. This is Dr. Jindal and this is Mr. Subraj. Next. This is where we are training them on glucometers. Next. And how to measure blood pressure. Now training is very important. I think if we train people to do a task, it is very easy for them to keep repeating that again and again. And most important is retraining to make sure that they have maintained their skills. Because these people, after all, they do other things and they tend to forget. Next. This is a road leading to, this is almost like in India, you know, villages and houses. These are separate houses. Next. This is the home of this sevak. This is his grandmother, his mother. Next. He's doing a screening test there. Next. This is house. Most of the houses in rural area, they have a lot of canals in Guyana because it's below the ground level. Next. I still have some time? 5 minutes?
Yeah.
Okay. Next, this is another sevak doing screening. Next. This are the houses, and behind the houses are the farms. Next. This is one of the sevak whose house is this. So there is absolute poverty. You see the toilet there, that's in the back of the house. She wants to go to medical school, this particular sevak. Next. Now, role of engineers. I've been telling people that 75% of the health problems are because of engineers. Nothing to do with medicine. And the engineers get upset with this because they've never thought in these terms that why is health our problem? But it is. If you look at environment, sanitation and habitation, all engineering issues, nothing to do with medicine. Medical guys somehow haven't been able to separate this out and put the blame. We basically take responsibility for anybody who has any health issue. Preventive, health disease, chronic disease, acute, everything. But if they did all these things, create new cheap buildings. I've been talking to some people and I said, if I want to replace an entire village in one day, can I do it or not? And they start thinking, but if you had prefab jhopris, you can do it. In Dang, all the jhopris are made out of bamboo, mud and cow dung. So if you had a chemical to it, you could probably sustain it for many years. And nobody even has done a study of the environment in a jhopri that if you have a floor made out of cow dung and mud, how safe is it? Because it does have less mosquitoes, it's warm in winter and cool in summer. So there are some benefits. Next. And then we talked about create a central point of information, create research centers. Village problems must have village solutions developed in the village using village resources for the villagers developed by IIT because I was addressing the IIT group, but it applies to all engineers. Next. Now WHEELS, Water, Health, Education, Energy, Lifestyle, Security, they form this organization. And in response, they do have healthcare in the thing. And we have an MOU in place between API, American Association of Physicians, and WHEELS. Next. And we talked about technology solutions, and we have been talking to IIT Gandhinagar also. Mr. Mehta is retired industrialist in New Jersey, and Mr. Madhu Reddy, both are alumni of IIT Bombay, and both have been involved heavily in building RO plants. Now here is a question to the audience, and I'm sure a lot of you have all kinds of friends. Why don't we have a matrix for water in India that if the water quality is this, it needs a single filter. If it's this, it needs dual filter. If it's this, it needs just softener. Everybody does not need an RO plant because RO plant has 60% rejection water, which is basically wastewater. You can't do much with it. If you try to recycle it through, then your maintenance of the RO plant becomes very expensive. Mr. Sanjay Daswani is Habitat for Humanity India, and we all visited this village, Agya, in Sabarkantha district. Next. And the partnership with WHEELS has been very beneficial to us. Next. We also had American Heart Association come to Baroda train the sevaks to address the problem of children below the age of 5, of how to decrease their mortality. In India, of course, there are a lot of issues with this because they take the person child to a temple or to one of those alternative type of person who is not trained in healthcare at all and waste valuable time. Wiz is putting an RO plant there and they have partnered with us for toilets. Next. Now they also have provided us with 32 netbooks to collect the data. And IIT Bombay conducted the training. Next. Let me go through this quick slides. These are few. This is a prefab toilet. Now if you try to find, India has 600 million people without toilets. But there is no single model of toilet that you can go and say, I want 100 of these toilets. It's just not available. And you say, why? Because no R&D has actually been done. So we got the second best solution. This is a builder in Ahmedabad who built these toilets. He's got these pre-blocks that you just assemble. In one day you can do this toilet. Next. Next. This is a portable RO water that can go to 6 villages. Next. This is Mr. Mehta. He's addressing the IDEA group. Next. This is during the inauguration of the water plant which is in the back and the toilets. Next. This is the RO plant. This person was Mr. Kirti Bhai. He just died 1 week after I got back to US. Next. This is the RO plant. Next. This is the inauguration of the toilet. Next. Never see that anywhere. But anyway, so coming back to, quickly I need to address one issue about the house that you have. In India what we have is between 6 villages there is a primary health clinic. And between 7 primary health clinics there is 1 community health center. And for 4 community health centers there is a district hospital. That's how it has been structured. And at the lower level, you have the ASHA workers. And now they have Anganwadi workers also that deal with children, give them nutritious meal at lunchtime. So there are programs in India. Now, the important thing for NRIs, if they can help India, is how to make these programs in existence more efficient. That's where we should concentrate. Narendra Modi gave me the original permission to do this project. 2 years later, I went back to him and said, all these sevaks are complaining that there is no blood pressure and diabetes pills in these PHCs, because that's where the sevak would refer the patients to. He said, okay. He didn't promise anything, but 9 months later, blood pressure, diabetes pills started coming into the primary health care centers. So it's a big issue because it comes into crores of rupees when you budget something like blood pressure and diabetes pills. The point I'm trying to make is we can make a change by moving the system. If the system is in place, inefficient, corrupted, and if we move, we can do this. At village level, there's nothing, and I think screening is the best. And as you emphasized, prevention is the key in all this. Thank you very much.
Thank you so much, Mr. Patel. I think we are running out of time, but we have a couple of questions. I'm going to make one comment, and that is, we see the model. I want to see the picture for the building. I want to see a strategy. How are you going to make this into different regions? That is one thing I'm feeling I didn't get.
I forgot the most important thing. This is open, okay? Anybody in any state wants to do this, I can give them all the slides, everything, how to do it. Just find one champion locally in India